Okay, good afternoon, everyone. Welcome to our, I think, fourth or fifth Criminal Justice Connect series. These presentations were put together based on requests from community members to have a little bit better of an understanding of the criminal justice system, some of the work we do, our partnerships with human services, and some other topics of interest that really come up often in our work as criminal justice practitioners. And one that got a lot of interest was understanding better the needs in the criminal justice system of folks that have a drug and alcohol treatment need or mental health needs. So this topic is specifically focused on the criminal justice aspect of those things. We could have many and multiple separate presentations of general drug and alcohol, of general mental health, but we're trying to kind of narrow in, give like a high level overview of the forensic needs of folks in those and some programming options that we have available to folks through our justice system locally. So you'll hear from some wonderful speakers today. I'm going to introduce both of them before we go any further. And starting off, we have our Director of Drugs and Alcohol Services, Kristen Varner. Kristen received her BA from Shippensburg University in August of 2000. She worked previously in the RACE project. She worked as an assistant at WHTM ABC 27 in Harrisburg. She was appointed to the Citizens Advisory Committee for Cumberland County Children and Youth in 2013 to serve as a representative of the recovery community. Most recently, Kristen was appointed to the PA Advisory Council on Drug and Alcohol Abuse. As an active member of the recovery community, Kristen has volunteered on several community-based committees, such as the Substance Abuse and Prevention Coalition, Sarah's House of Hope, Cumberland County Opiate Overdose Coalition, the Dauphin County Heroin Overdose Prevention Education Collaborative, the HOPE Collaborative, and Dauphin County Capital Area Reentry Ex-Offender Support Coalition, or CRESIC. Kristen is a certified recovery specialist and has been in recovery herself since 2005. Kristen was employed by the RACE Project, a local recovery community organization, from 2007 to 2019. During that time, she oversaw all Carlisle RACE programs, facilitated RACE educational trainings, maintained the In My Own Words Speaker Bureau, and was responsible for all RACE advocacy efforts. Kristen accepted a position as the Dauphin County Director of Drugs and Alcohol Services in October of 2019. She currently oversees all aspects of prevention, intervention, treatment, and recovery supports for Dauphin County. She resides in Harrisburg with her husband and 4 children. That's just our first speaker. Our second speaker is Dr. Ashley Yinger, and she received her doctorate degree in late 2019 in criminal justice administration. She's worked in human services, criminal justice field since 2007. She started in the district attorney's office here in Dauphin County in 2018 with a focus on the Stepping Up initiatives, which is a process and by which you reduce those with severe mental illness in jails. Much of her focus is behavioral health on the front end of the system and back end of the criminal justice system. She serves as the coordinator for crisis intervention CIT training that started in late fall of 2019 and oversees the Dauphin County co-responder program model that started in the spring of 2020. Prior to coming to the DA's office, she served as the mental health administrator for Franklin Fulton County. Research interests of hers have included CIT training, vulnerable populations in the criminal justice system, reentrance, impacts of behavioral health and criminal justice involvement, victimology, and other areas along those lines. So we're really pleased to have both of them today, and I really appreciate everyone taking the time to attend. So with no further ado, Kristen, I will turn it over to you. If you have any trouble sharing anything, let me know.
Great, thank you. The first thing I'm going to do is, of course, go ahead and share my screen. So just give me a moment. I'll get that up. And beginning. Slideshow. There we go. Okay, so thank you for having me today. What we have today is also the deputy of Dauphin County Department of Drug and Alcohol Services. Her name's Natara Ayanakone. She just put, yep, there she is, waving her hand. So she's going to help us out a little bit, answering questions or maybe, adding some insight. So if you hear her talking or anything, she's has a wealth of knowledge on this topic. You know, our first screen does show us the, let me go back here for a second, our building. What you may notice if you've seen the building for Dauphin County Department of Drug and Alcohol Services is that the name Drug and Alcohol Services is not on the building. And we have done that on purpose, you know, way before my time, obviously. But so individuals can come into our office and receive care without the feel of being stigmatized for receiving services. There's also a CMU, which is located at the same building. So some of you may have noticed this building driving throughout Harrisburg. We just simply refer to it as 1100 South Cameron. So that is where we're located, but we also work mobily. So just because we're located at that building does not mean that we go out to the jails a lot. We do, we visit people in the community. We go down to children and youth. We're very mobile. So please don't ever let that stop you from making a referral or for requesting services for somebody. And basically, our mission is to serve those affected with substance use disorders by providing high quality prevention, intervention, treatment services, and recovery supports in Dauphin County. And our vision is to provide accessible and comprehensive care for both adolescents and adults that need prevention, treatment, or intervention services. And like Catherine said, we're not going to get, you know, if I sat here and talked to you about what we do, you know, all day, that would be a much longer training than what we're talking about here in the next few minutes regarding specifically to the criminal justice population. So what you see here is a slide of two of our individuals and two of our current case managers, and both of them do work within the criminal justice case management arena. What you see here is them out actually at one of our homeless outreach events, you know, just basically intervening in the community, offering services. And that's kind of what we do. We would like to be doing this on a weekly basis, you know, but COVID hit and we had to go to like a monthly basis, but now we're trying to get back to that weekly basis. We're out, we're in the community, we're at certain sites where we know that there's a large gathering of homeless individuals, and we promote our services basically. And we do feel that the more contact we have with certain individuals, the more apt they may be to accept help in the future. And you know, just looking at this picture now, you can tell it's such a current picture because they do have their masks on. You know, way to go 2020. So what else do we do? We have prevention services. We do have 8 providers and that do some of our prevention services, including us is the SCA. That's not included in the 8 providers, but we also give services, prevention services. We perform groups, we sit at SAP meetings, and we do referral to treatment. Our intervention services, we have 2 providers in the area that perform intervention services, plus we also do intervention here at the SCA. SCA stands for Single County Authority, for those of you that may not be aware of what Single County Authority is. Basically, all throughout the state of Pennsylvania, each county is responsible, and some counties are joinder counties, which means there's 2 counties in one, but each county has a single organization that is responsible for providing treatment services, recovery, intervention, and prevention to the underinsured or the uninsured. So that's really where we come in, especially with the criminal justice population, because you know that most individuals may be very underinsured and uninsured at most times. So that's why we go in, we do the evaluations in the jails, we help individuals, we place them into treatment, and we set them up so that they can be successful in the recovery efforts. As far as treatment services, you know, are talked about within this community, we have 56 providers that we can refer to. We do have a lot of providers that are very heavily criminally justice minded, such as Gadenzia, you know, there's Conewago Place. So we know which ones that we need to refer to meet the needs of each client that we're assessing. And we do have recovery services. We have 3 providers that are giving recovery services throughout Dauphin County. Plus at the SCA, we now have 2 recovery specialists that assist us in our specialty courts. Really, they're worth their weight in gold. Both of our recovery specialists that we currently employ have a background of being incarcerated. So they know what that feels like. They know what it's like to be incarcerated and then to come out and then to see all of the different obstacles that are within, their way to achieving full recovery. And I really think that is unique to our SCA. We do hope to employ more recovery specialists in the very near future that can kind of build up this network and really take every individual that comes to our office that has some sort of criminal justice background, involvement with the criminal justice system, and lead them through this process. For impact, what we do is about 3,000 individuals have received case management services through the SCA. We do funding, screening, assessments, and case coordination. And the 3,000 individuals that receive case management is for the fiscal year 2021. We had 105 intensive case management individuals. We had 30 individuals go through recovery support services. We served 11 school districts, 3 hospitals, 330 individuals were seen through our warm handoff efforts. And as much as I would love to tell you all about our warm handoff program today, I know that's not why we're here, but it's a really awesome program that we have, is where we can actually meet individuals at the hospitals if they end up there, unfortunately, through an overdose or just because they don't know where else to go. And we'll see them 24/7 and refer them to treatments. We've also reached individuals through community support groups and through our homeless outreach. Now, what we're going to talk about right now is what we're seeing is really our drugs of choice. Our largest, contrary to what you may see on the news, yes, opioids is a huge problem. And if you've seen the newest data, they're talking about how opiates and the actual overdose have increased by 30%. And that is a very true fact. However, what we're still seeing at our office is the #1 drug of choice is alcohol. And that is very closely followed by opiates. And then you see your marijuana, your cocaine, and then other. So, I do feel that some of this alcohol, which alcohol has always been one of our, main drugs of choice that we've seen. However, during the pandemic, we saw an increase in alcohol related assessments coming in and individuals seeking help for alcohol. And also nationwide, we saw an increase in females presenting with alcohol use disorder. And, you can kind of understand where that came from. We were all stuck at home, a lot of times with children, not many social supports. All of those had been very severely cut. And, boredom, sense of, boredom or other feelings came about, and alcohol seemed to quench those at times. And as a result, individuals that may not have had their disease progress to the disease state, we saw individuals very rapidly present with alcoholism, and their disease turn into that. So we're going to be seeing individuals with alcoholism probably for a long time, and an increased rate. But our referrals, if you look at the other pie chart here that's up here, our referrals just from the criminal justice system is at 42%. So that almost accounts for half of what we see referral-wise. And that can come from many different sources. A lot of our criminal justice referrals obviously aren't from individuals themselves. We would like to see individuals themselves referring them, but we do see a lot from probation officers, from the jail, from our booking center. So we're very, very busy when it comes to criminal justice. So when I'm talking about, the things that we're seeing, you have to think that almost half of these individuals are being made up by referrals from the criminal justice system. We're seeing about 25% as self-referrals, just 5% from providers throughout the county and other counties who may have had an individual from Dauphin County show up in their office. We see about 7% from county human service agencies, 9% from hospitals. We see just about 2% from schools, and then about 10% from other. And, when we're talking about our criminal justice population, the most important thing to remember is that communication with our partner agencies is absolutely essential. So that's really where the coming of the release of information is so important. A lot of times we'll see someone with that's involved in the criminal justice system may not want to share, that they're in a specific provider. We always try to encourage them that we're there to help them, and that, anybody that is, trying to follow them through the criminal justice arena, such as a probation officer, a judge, somebody, like, they want to see them do well. So if they are able to share and they are able to sign those releases of information, we're able to more effectively do our job. But we can't, unfortunately, it's fortunate and it's unfortunate that when we're talking about drug and alcohol, we have a release of information that kind of trumps almost all other releases of information and other human services. We're very restricted with what we can share. So we got to make sure that we get these releases done right, and we have them done at the time of intake with any type of individual coming from the criminal justice system. Just a little side note on that, releases of information for Pennsylvania are actually more strict than the federal definition of releases of information for drug and alcohol. So that just goes to show you how strict these releases of information are. There's some legislation going around that, is asking to change that, but for now we have what we have. And, really just the key is to get them to sign it. And, we're still not going to release anything unless it's signed on both ends. Advocating for treatment over incarceration is always based on the individual's need and their situation, and helping the individual understand that treatment is not punishment. And a lot of times we say that because, an individual may be assessed at going to a higher level of care. Let's say that they relapse while they're in a specialty court or something, and we give them an assessment and they're assessed at going to a higher level of care. A lot of times they can look at it as a punishment, and we have to use motivational interviewing to explain to them that, like, no, this is for your best interest, and all we want to do is help you get better. And sometimes that can only be established through going to like a higher level, such as an inpatient program. We also need to address criminal thinking and behaviors in addition to addressing the addiction. And that's really what the disease of addiction is. It's very important that when we talk about the disease of addiction, you understand that it's not just about the drugs that these individuals put in their body. And myself included, as Catherine, told you all when she did my bio, that I am a person in long-term recovery. And we really do look at the drug as just a symptom of the disease. The disease of addiction is really all about behaviors. And when we're addressing those behaviors, we can get someone to stop using the drugs, but if we don't change their behaviors, such as sometimes people, like for instance, have a compulsion just to steal. They have no reason to it. They may have everything that they need. They have, all of their needs met, but that feeling, that high that they get off of simply just taking something, or what we need to work on in order to address their behaviors, because if not, they may end up back in the system. And if they end up back in the system, it becomes a snowball effect where they're like, why do I even bother? And then they feel bad about themselves, and then they go back to using. And what about our barriers to treatment? And I thought a lot about these barriers to treatment, and I asked, a staff member to kind of help me out with this, as well as Natara. And, one of the major barriers is that there's not enough beds as there is need. So we may find an individual needs a inpatient level of care, but we can't get them to the appropriate treatment center just due to the fact that there's not beds in the treatment center that we want to send them to. Providers will also not accept some charges, such as sexual offenses, arson, strangulation, and various assaults. It's very, we really have to do our job on our end to explain that maybe some of these incidents occurred while the person was intoxicated. And generally, if they're coming through our system, we know that was, the point, that the boiling point that made them do certain things, but providers still won't accept them. So as a result, we need to send them to a different level of care that may not be appropriate to them, just because the liability of the provider saying, hey, we're still not going to take them due to their charges. So these charges are going to follow these individuals for a very long time, as you all know. There's also limitations to addressing medical and mental health needs. Depending on what type of medical need an individual may have when they're incarcerated, moving them out of that into a facility for treatment may be very difficult, depending on what the treatment facility will offer. Currently there's only really 2 inpatient facilities in the state of Pennsylvania that take individuals with medical needs. And, it's very hard to get beds in there as well. So we go back to the first point where I said sometimes there's not enough beds. There's also language barriers. Sometimes they may be assessed. Individuals may be assessed to go to a certain level of care. It could be outpatient, it could be inpatient. And also the judge has said, yes, you've been assessed at this, therefore you must complete this. But our problem is that we don't have the providers sometimes at that level of care that can address issues that also speak the same language. So therefore, an interpreter needs to be hired. All sorts of things need to be happening. And as a result, again, they're not getting the level of care that they need. And something that I was thinking, especially for this next one, is the returning to incarceration after inpatient, which I understand, the need. Sometimes individuals are let out of incarceration to go to treatment, and then after they're done, they're asked to come back. So when we look at the disease of addiction, what we're really dealing with is like a disease that affects dopamine levels in the brain. And I'm not going to get too far into this, but what happens is if we would give brain scans to individuals that are in very early recovery or the very end of their addiction, like right before they stop using the drugs, and we would give them a brain scan, most of the times you're going to find these very, very low levels of dopamine. And that's because the drugs essentially deplete all that. The very easy way to say that. So it takes a very long time. Like first of all, you have to stop putting the drugs in your system. And then it takes about 1 year to 18 months for your brain to get back to where it was before you ever used. Okay. So what helps that dopamine recreate faster are positive life experiences after you put the drug down. And that usually happens and occurs through the recovery process, through mutual support groups, through meeting new friends, through finding new hobbies. When an individual is sent back to, incarceration, it's very difficult to have that dopamine replenish itself. I'm not saying that they don't have joy in their lives, but, living life to the fullest usually isn't something that they're able to do while they're incarcerated. So it just kind of delays that process a little bit. And they're not able to go out and build a support group, which is so very, very important to an individual, especially in early recovery. Because, it's important to note that any individual in the recovery process, it's going to be almost impossible to do it by themselves. They need some sort of social support to help them. Transportation is also a problem, depending on, where they're going, what stage they're at. Maybe they're not incarcerated anymore and they're living in a recovery house, or they're living, wherever their home plan has put them. Sometimes they don't even have the transportation available to get to the certain support groups or outpatient programs that they need to. And the last one is stigma. And, I think I kind of talked about stigma in the last slide when I talked about how certain providers won't take individuals with certain charges. And, stigma is very real and it will follow them. And the stigma of being in prison, the stigma of trying to get a job when they're looking at, potential employers looking at, why they were in prison to begin with, how long they were there. Oh, and now on top of that, you're telling me that you might possibly have a drug and alcohol need. That's a lot to deal with. So there's a lot of barriers to treatment that is really starting these individuals at a negative, level, it's not even a level playing field. So they're below the level playing field. And our job, especially here at Drug and Alcohol, is to try to help them eliminate as many of these barriers as we can. We do a lot of this with our certified recovery specialists, taking individuals by the hand and walking them through these barriers of treatment and seeing if we can't get to the other side. And, just so you know, we are always here to help. And how do you connect? Our phone number is up here. We do have a 24/7 line. So if you were to call us after hours, it would be transferred to the answering service. And at that point, depending on the need of the individual calling, if they're looking for immediate treatment, we will be able to answer that call. It goes to a provider that we have contracted out with just for today. Veteran services. However, if someone's calling, what we do sometimes do is we get calls after hours saying, I was told to call, I need to get an assessment in order to comply with court or something. Those are calls we don't handle in the evening after hours. We do handle those just during our normal business hours. And 1 second. We provide funding, again, for treatment services to Dauphin County residents who are uninsured or underinsured, and we do a liability on a sliding scale. So I don't think we're going to do questions now. I think what we're going to do is keep going with the presentation, but keep putting your questions in the chat box. Or just write them down and hold them for when we're done. Please make sure to follow us on social media as well. Thank you.
Yes, thank you very, very much, Kristen. And yes, please do put any questions you have in the chat box. We'll make sure to get to those as we go along. And now certainly, second, but certainly not least, because we all work together as a team here, I'm going to turn it over to Dr. Yinger. Give me 1 moment to pull up her PowerPoint presentation, and I'll turn it over to Ashley.
Thanks everyone for having me. So as Catherine mentioned early on, the focus on, I think we could sit here and talk a lot about mental health, criminal justice or non-criminal justice related, but I'm here today to primarily just speak on mental health as it relates to our criminal justice entities, on the initiatives that we're focusing in on. And our biggest thing that we have in the county right now is what we call our Stepping Up initiative. In 2016, Dauphin County, the commissioners signed a thing to recognize Dauphin County as a Stepping Up initiative where we look to reduce serious mental illness in jails. Catherine, you can go to the next slide. And what we had during 2015 and 2016, we actually received technical assistance from CSG, they're the national entity that looks at all the states in relation to stepping up. And they reviewed our data, our gaps, our service providers, just very basic front end and back end. And they came out with a report in 2018. And one of our very first goals was bringing in someone to coordinate and oversee those initiatives. And that is one of my primarily responsibilities in the district attorney's office. And through there, I pulled together a subcommittee, which is off of our CJAB, and we really kind of dived into what were the recommendations that CSG put forth of what Dauphin County needed to kind of really focus in on if we were going to make lead way in reducing serious mental illness in our Dauphin County prison. Next slide. And so the biggest thing that Stepping Up looks at is 4 key measures: the reducing jail bookings as a whole, reducing the length of stay, increasing connections to treatment, and decreasing recidivism. And because what we were seeing as like a national figure, looking nationally, there's about 20% of individuals that have a serious mental illness. In Dauphin County, when they looked at our data back then, it was 16%. So that was seen as, relatively high. Individuals that were staying in Dauphin County Prison with a mental illness were actually staying in prison much longer in comparison to someone that did not have a serious mental illness. And so we knew we needed to kind of focus in on reasons, why were they staying at longer periods of time? Because generally speaking, when they were looking at risk assessments, when CSG was doing the data, and even as a whole, individuals that have a serious mental illness, just that serious mental illness itself does not mean that that person is automatically a risk factor of being violent. And so, we really wanted to take a look at, what were some of the barriers as to why they were staying much longer. I can sit here today and say that based on the initiatives that we are doing in Dauphin County, which I will go into greater detail in, but through those initiatives for at least over a year now, I can sit here and say that individuals with a serious mental illness are being released from Dauphin County Prison sooner than someone in comparison who does not have a serious mental illness. So when this report came out, individuals with SMI were staying longer. They are no longer doing that. So we have been able to make great strides in our initiatives for that. So you'll see just on this slide, this was some of the information and the data that was pulled from CSG of just giving us a start at what things look like. Mental illness definitely, it has not went away. It's not going to go away. And even though we have made great strides in our data, in our initiatives, it's definitely still a problem in the criminal justice system. Early today, I think the total of individuals at Dauphin County Prison was 981. I get a weekly report of individuals that fall in the mental health category. And in the beginning of the week, we had 112 individuals that have a serious mental illness in jail, and 329 that just are diagnosed with some level of mental health. So you, looking at that math, you have about 441 people out of that 981 that have some level of mental illness. That is just shy of 45%. So we are close to almost saying that pretty much half of individuals at Dauphin County Prison have some level of mental health. Our numbers have definitely went down, but it's still serious at the same time where, we're seeing almost half. It definitely was well over half, so I can at least, thankfully say that it's under half now, but we still have a lot of work to do. When we talk about the D roster of individuals, so what are we seeing? When we see individuals that are in Dauphin County Prison, what mental health diagnoses are we seeing? So when we talk about the D roster in Dauphin County Prison, the D roster is individuals that have a serious mental illness. When we talk about serious mental illness, we're really looking at just a small category of that their diagnosis may be schizophrenia. And schizophrenia is broken down in different subcategories where they may have schizoaffective disorder. But generally speaking, as a whole, some level of schizophrenia. They have bipolar. And bipolar in itself can also fall into schizophrenia and major depression, depending on what type of bipolar someone has. And then major depression as a whole itself, outside of bipolar, or just strictly having major depression. They are the top diagnoses that you see when you talk about a serious mental illness. So someone that is falling on that D roster in Dauphin County Prison, you're going to look at those diagnoses. When you look at someone who just has a general mental health that does not fall into the category of serious mental illness, you may see adjustment disorder, anxiety, like general anxiety, a lower level of depression, PTSD, the post-traumatic stress disorder is very common, that someone having trauma is extremely high. And a co-occurring disorder is extremely high. So when I say co-occurring, I'm referring to drug and alcohol. It is very common that someone who has a mental health disorder, they very well may also have a drug and alcohol substance use disorder. And so, it's not, sometimes the perception is that, individuals that are incarcerated, they may have that schizophrenia. That can be true, but it's actually more of a smaller population. Speaking just non-criminal justice and related, one of the mental illnesses that is actually the highest proportion of like a national standard is actually anxiety disorder. Roughly about 20% of adults may be living with anxiety, and that's, just generally speaking, not necessarily with criminal justice related. Below that, I would say roughly about 6% is what we see the major depression disorder. And then actually it kind of falls into the substance use disorder after that. So some of the more serious mental illnesses, such as schizophrenia and bipolar, they do not make up a huge population percentage. But that just kind of gives you where we stand at today with looking at some of the numbers in Dauphin County Prison. So still much more work to be done. Next slide, please. So some of the things, if we want to make improvements, and even though we have already made a lot of improvements, but still work to be done, I want to kind of just, the next portion of wrapping up kind of this PowerPoint is really going to just kind of dive into letting individuals know what are we doing in the criminal justice system when we partner with human services in relation to mental health initiatives. So I already mentioned that I help coordinate our initiatives and overseeing, what departments are doing in regards to kind of reducing that serious mental illness. Early on, we started with the pretrial risk screening assessments out at booking. Pretrial went out to the booking center, and they use a tool very adapted from the Allegheny tool, and they do a pretrial risk screening and really looks into what is the risk factor of someone showing up to court and the likelihood of them getting new charges if they are out on bail. They started that in November of 2018. We have seen a lot of progress out of that. Currently, our diversion specialists are doing that, and I'll get into their role a little bit later. But ideally speaking, when someone comes into the booking center, they've been charged, the individual gets a risk screening done with them, and then that screening gets sent to the MDJs to take a look at prior to arraignment. The diversion specialist complete screenings out at booking, mental health and drug and alcohol screenings. And this really is kind of get an idea of, who are we seeing out at the booking center? What are the treatment needs? And as I mentioned earlier, roughly about 0.5% of people at the jail that have a mental health, we actually see about, it has varied. So I'm going to kind of give you a broad range, and I'm going to say about 35% up to about 45% of individuals that come to the booking center with new charges have had identified needs of some level of mental health or drug and alcohol. It has varied month to month. I will say in this last month in June, we saw individuals with higher mental health needs than drug and alcohol. But I would say in previous months, we've seen more drug and alcohol needs than mental health, but the numbers are not off by much. They're very close. So it really just gives us an idea of what are the treatment needs coming into. So again, about 35 to about 45% of individuals coming into the booking center have identified some level of treatment need, whether it be strictly mental health, strictly drug and alcohol, or the combination of both, as that co-occurring disorder is extremely high. And so the diversion specialists, when they're completing these screenings, again, that is being told to the MDJs that this individual does have a treatment need, and we do need to link them up to treatment. We might need to get a further mental health or drug and alcohol evaluation, get level of care, medications, CMU, the case management unit involved, even drug and alcohol. So they almost serve as like interim case managers to try to identify some treatment needs. Those diversion specialists can help the individual prior to being released out at the booking center to make sure that they have an appointment scheduled, that this is where you're going to go at this time and place to get this evaluation set up. I know there were some hesitations with these screenings being done at booking. Would this put a greater stigma on individuals with mental health? Because sometimes, it's scary for someone to come in to the booking center and say, yes, I have a mental health disorder, because of that fear that if I tell them I have a mental health disorder, is that in itself going to keep me from making bail? And we don't want that to be a factor whatsoever. And so a lot of things go into place whenever that bail is being sent. But our goal is to not put any stigma on if someone has a mental health or substance use disorder. It's simply to make that judge aware that this person has a treatment need, and we need to see how we can help that person the best case scenario. Unfortunately, if they do have to go to the prison, then that information is shared, so that's way treatment can get started with that individual, medication or particular classes. We started our CIT training, crisis intervention team training, team MISA, team mental illness substance abuse, and we also have a reentry team, a co-responder model, and increasing mental health services. These are our primary focuses right now when we talk about our stepping up initiatives with mental health and the criminal justice factor. And I'll get into some of these greater in detail in the next few slides. So next slide. So our CIT training, we started this in the fall of 2019. It is an evidence-based model. It's a 40-hour training that really goes into increasing the knowledge and awareness of mental health, behavioral health as a whole. It gives officers another tool in their tool belt to say, you know, I might be able to connect this person to treatment rather than incarceration, or this is how I might be able to help de-escalate this person in this situation. So the training really is broken down into a lot of different factors. It really starts off with just a very general knowledge of what is mental health, which really is, it's a diagnosis that really impacts the person behaviorally, emotionally, physically, and it impacts their ability to kind of do some everyday life thinking skills and living skills, whether it be at their work, their home, and out in the community. And so it really kind of helps set a very basic knowledge of what are some diagnoses, what are some behaviors you may see with that. And so it really kind of helps the officers know what they may be looking at, that someone, just because they behave in a certain way, does not always necessarily mean that they're under the influence of drugs and alcohol, or vice versa. It doesn't always mean that they have mental health either. I really, in day one, they get to hear from people that are living in recovery. Because sometimes, you know, working in the criminal justice system, we see people at their worst, and that may or may not give someone a stigma to that. So I let officers hear that people that are going into recovery do not look any different than you or I, and that they can hold jobs and they can have good housing and family support. And so the goal is to really reduce that stigma. Throughout the week, they learn more about substance use, autism, intellectual disabilities, veterans, PTSD, homeless, cultural awareness, problem-solving courts, you name it. It's a realm of human services to really kind of give them some resources that, you know, if they don't take the person to booking and they know that they have a treatment need, well, where can they take them? So they really learn about a lot of the resources through the week. And then as part of the crisis intervention, they really learn about active listening. I tell officers that the biggest part for CIT when it comes to de-escalation is using your ears and really listening to the person, and then our mouths, and seeing where we might be able to support them at. Because oftentimes someone that is going through a mental health crisis, they just want to be heard, and really going through that suicide prevention and awareness training. I can say that I give a pre-test and a post-test at the beginning of the week and the end of the week. And throughout of all the trainings that we've had thus far, we have had to unfortunately cancel a few due to COVID restrictions, but I have gotten nothing but positive results from this CIT training, that it has increased awareness, it has increased knowledge, it has reduced some stigma that officers may or may not have had. It helps them be more confident and comfortable in approaching someone that might be going through a mental health crisis, and how to address that and where to send them to for help. So I've gotten a lot of feedback from it, to the point now that I don't even need to put out a registration, that I already have chiefs telling me, hey, please send these officers through. And so our next training is in August. It's actually going to be for the state police, and then countywide in September, and I'm actually already full for both of those classes. So now I'm looking at another one before the end of the year in December. So the classes are getting full. Even officers that go through it tell me, you know, I'm not so sure about this. And then at the end of the week, they get a hold of me, or even afterwards, and say, wow, that was a really good training. I didn't think I was going to use the tools, and I've already used them, you know, the following week. So that has really been a key factor in our office and in the county as a whole, working with law enforcement. That is our primarily audience right now, is law enforcement. But as you see here, correction officers have went through it, diversion specialists, treatment specialists, our co-responders, our treatment courts, crisis intervention. So the training does not need to be police officers by any means. It's just our focus right now is to get police officers trained, and then we will continue to increase probation and corrections and other human service entities as well. Moving on, after we started our CIT training, we started our co-responder model. Our co-responder model is a mental health professional that's embedded with law enforcement. Right now, we partner with Harrisburg City Police, Swatara, Susquehanna, Lower Paxton, Derry, and Hummelstown. I have co-responders. They are district attorney employees, but they report to those departments that I just listed. We have helped out other departments outside of that. Oftentimes they will call me, and if I can't respond, I will get another co-responder. So we've helped out various of other departments. It's just right now based on grants, funding. We've just been able to put full-time co-responders within those departments because looking at data, they've been the departments where we see the most mental health calls, but we absolutely are always looking at funding opportunities to increase. If I could put a co-responder in every single police department in Dauphin County, I would love to do so. Hopefully one day we'll be able to get there. So, but right now we focus in on those departments and then help out the other departments when they call in and needing some help. We started this in March 2020, and again, it continues to get nothing but positive results. The co-responders, they kind of almost serve as case managers. They can ride along on scene on an active call, be able to help de-escalate, be able to link the person up to services, and just be there as a support to the individual in crisis and the police officer responding. I would say, you know, looking at just this year itself, so I know we're still clearly in 2021, but just looking at the first 6 months of January through the end of June, we have gotten 596 referrals. So just shy of 600 referrals where there was some behavioral health need, where the co-responder helped link that person up to treatment or help de-escalate them, a variety of things. We've had, even in addition to that, we had just shy of 200 people. There was 186 of those that are repeats. And repeats may be that we are continuously trying to engage that person into treatment. And until we do so, they've had some frequent law enforcement contacts, so they're repeats. So 782 contacts already just in the first 6 months where co-responders have been involved in calls. And I can say out of those 782 referrals, only 46 of those have resulted in charges. So we are seeing that when the co-responders and law enforcement are jointly working together and there's a behavioral health need, that co-responders working with mental health partners, drug and alcohol partners, aging partners, homelessness services, food services, children and youth, and we've been able to really reduce the number of those calls resulting in charges and linking them up to services instead. So the co-responder model has been going extremely well. Next slide. So I kind of already mentioned about the diversion specialists and one of their biggest, what they focus in on, and it's completing that pretrial risk assessments and the mental health and drug and alcohol screenings out at the county's booking center. And then they coordinate with prison entities and community entities, really trying to see where they can divert people and link them up to treatment when appropriate and as necessary. Our team NISA, so if individuals do unfortunately have to get charges, but we know that there is a serious mental illness involved and we really need to focus in on those needs, then our office and the district attorney's office has taken lead where myself and an attorney, we coordinate it and we look at those new charges and we try to see, you know, what is that treatment need, and then looking at their criminal history, looking at their new charges, and then we have the full team, and the full team really comprises of the prison, prime care to be included, which is the mental health provider inside the prison, the diversion specialist, if they did those screenings at the front end, pre-trial, mental health, drug and alcohol, the work release center, the public defender's office, probation, And so it's a large team of us that looks at this case then as a whole and see where we might be able to help that individual out. It may become part of their sentence. We might be able to divert them. There have been a multitude of cases where we've identified that this person really needs inpatient level of care. Can we modify their bail, get them inpatient, and then get them stabilized and then address their charges throughout that criminal process? They may have to stay in the prison, but then they hit their mandate, for as an example. And then we know, though, to be able to come back out in the community, they need to have those services set up. So if they become sentenced, we have a reentry team then that comprises of majority of the same people, or at least same entities. And they look at individuals that are sentenced and how can we link them up to treatment prior to release. So it's really looking at that front end, pre-sentence, and that back end where they're sentenced, but we know that they have identified treatment needs. Again, kind of just looking at the first 6 months of data right now, and this year we have looked at 160 cases. Now, oftentimes we do sometimes run into barriers where they are looking at, they're not Dauphin County residents, they're out of county. Or we have came across some very significant charges that unfortunately we have to process those first. So not all of those cases of the 160 that we've assessed have actually became like MESA cases that we've been able to divert or reduce charges or reduce sentencing, but we've at least looked at 160 of them, and 62 have, though, already been released because we've set up some form of their charges being reduced or sentenced and got them into treatment, even it might have been even inpatient or a residential setting. And so 62 of those have been released. So we do continue to try to see how many people that we can help through our team MESA. So that's probably our biggest team approach right now for individuals that have a mental illness and or substance use, but that they do have charges tied to them. And so how can we still help them? We are looking at re-implementing mental health court. The goal for that is to start at the end of this year. Team MESA is extremely informal. We do try our best to make it as structured, but it is nowhere near structured as what we see in true problem-solving courts, our drug court, our veterans court, our mental health court that we did have a couple years ago. So we do think in order to make improvement in our Team MESA, to really help individuals that really do have some serious mental illness and charges, but really need some more structured approaches to them with increased case management and probation. We do think bringing back mental health court can get us in that right direction that we're focusing in on stepping up initiatives. So again, our goal is to bring back mental health court by the end of this year. I'm currently working on that with a few others, but we still want to keep Team MESA for individuals that may be more appropriate to stay on that Team MESA track as well. So that is our two biggest focuses when we come into contact with individuals that have charges. Next slide. So that really just wraps up. I wanted to kind of just focus in on our stepping up initiatives. So we are doing a lot, but they are our key focuses. Our county mental health department, as part of stepping up, they have implemented some new services. And I say new, they're not new being that they just started. They've actually started a period of time ago. But we do, with the work of the mental health department, they have brought in Live Up Recovery at PA Counseling. It is an intensive outpatient program for mental health and drug and alcohol. It can be a drop-in center up to 5 days a week or even 1 day a week. That is a treatment service that we find ourselves CMU connecting individuals the most with that are out in the community and referring them to that. If they need a higher level of care of residential, early this year in January, the County Mental Health Department did get a contract with CSG for a forensic residential program that's a 14-bed, it's a short-term 90-day program where an individual can go there and reside while they continue to work on their goals, of long-term goals of being able to then step down to maybe their own living environment, but this really kind of gives them the help that they may need whenever they might be stepping out of, say, Dauphin County Prison as an example, and they need that higher level of mental health care. So those two programs in itself, County Mental Health, CMU, we find being the most referrals that we see to the Live Up Recovery and the forensic CRR for individuals that are coming out of Dauphin County Prison, that we use the most through Team NISA and our partial hospitalization as well. But again, I know I probably hit you guys with a lot of information. I kind of wanted to just touch base on some of our key components of our Stepping Up initiatives that our office and the DA's office is really overseeing, but we're not doing it alone by any means. We are partnering with law enforcement, probation, work release, all of human services, mental health, and drug and alcohol. It really is a team approach. But I do like to think that we have been able to make a lot of strides. There's always room for improvement. And so we continue to look at that on a regular basis.
Thank you, Dr. Neer. I'm going to stop sharing here because I think I clicked during and things went at the very end, and I think another slide changed in. But thank you very, very much for that presentation. The good overview of kind of that forensic involvement that we do have. And I am going to put up one more PowerPoint here just to kind of tie this all together, to kind of take stock of give us like a roadmap of some of like where we are right now. So I'm going to share that. So give me one moment here. Go share. Okay. And okay, so just getting started here. Obviously, Kristen and Ashley are our presenters, and I don't know if I introduced myself now that I'm actually thinking about it. I'm Catherine Kilgore. I'm the Criminal Justice Advisory Board Administrator for Dauphin County. So we do, as a Criminal Justice Advisory Board, or CJAB, we do all sorts of projects related to how different agencies within the justice system work together and try to improve how we work together. So that can come in the shape of the Stepping Up initiative, that can come in the shape of any of the treatment court programs, grants related to these things, just general system improvements is kind of what CJAB is all about. So what I want to kind of wrap up with and leave you all with today is sort of a way to frame out all of these changes. You heard from Kristen that the kind of challenges that there might be broadly in the DNA system and forensics, those folks, how that sort of ties in. Heard from Ashley how much work is going into the county criminal justice system process related to those with a severe mental illness and often co-occurring substance use disorder, and the kinds of programs we're implementing to help as much as possible. But I hear this question a lot from folks of, what does that all mean? Like how what else do we need to do? Where are you doing this in the justice system process? So I bring up this slide, the intercept model, or sequential intercept model. It's a simple framework that was developed many years ago, early 2000s at this point, to help folks kind of map out literally in your system, in your flow, from even point of before contact with law enforcement all the way down to when someone comes back into the community. Literally map out what programs do you have and when they occur in the justice system process, because that can help you see gaps. We sometimes call the process of using this across systems mapping process, and then this model helps kind of list out at each point what programs you have. So this is a visual representation of that. And what I did to kind of tie this all together today is just sort of map out at each intercept, with a focus on the front end, especially because that's where have been the most changes. Focus in there on what kinds of programs we have. And Ashley covered them, I think Kristen did, but this will just kind of put it all in order for you. So starting at the very beginning, community services. You heard a little bit about some of that from each of our presenters today, but really early on in the law enforcement process, when someone is approached, when they have the potential to receive charges, if there's a drug and alcohol need, we implemented this in the LETI program, Law Enforcement Treatment Initiative, in it was early 2020. Or no, yeah, I think it was October of 2020, sorry. And kicked it off such that if the police departments refer to us somebody who has this need, that working with an attorney in our office, we may be able to not even charge that person, simply connect them to a treatment bed and move them to a potential facility. And if the person at that time follows through with the recommendations for treatment, then as long as we're getting updates, person staying connected, after several months, the DA's office will just ask the officer to just not even bring the charges. We'll say they've satisfied treatment, they're committed to it, they're sticking with it. We're not even going to have these filed. So there is an opportunity pre-charge to have somebody engage in treatment. It is up to them. They do have to want to do that. The district attorney's policy is pretty broad compared to some other counties that are doing something similar to this. So it's the police co-responders in particular that Dr. Yinger mentioned that help us get these referrals, but anyone can ultimately make a referral for this, and this is a pre-charging point in time that this option is used. We're one of, I think, 7 or 8 counties at this point that has something like this available. The Attorney General's office was instrumental and is instrumental around the state, trying to help roll these out and get more and more of these options so that folks can connect to treatment even before we would charge them. So continuing on the Intercept 1, you can see again early on we have the crisis intervention team training, which Dr. Yinger mentioned. 140 plus people have already been trained. Police co-responders, she also talked about that. So this is all early on in the criminal justice process. Again, the earlier we know something, the better and faster we can typically do something about that. Get a better sense of who's in our system, and then kind of what we might need to do in tailoring an approach that will work. Within reason. We have certain charges, or maybe there's if there's a victim involved. From the legal aspect, we have those things to consider. But as best we can, we try early on to identify folks with those needs. And we also have brand new the behavioral health unit in our office, and assistant district attorney. That is the attorney that Dr. Yinger mentioned, that I mentioned earlier, that we consult with on a lot of these cases. That position was created specifically to pay attention to these particular cases, and to make sure that we have one person fully and completely reviewing referrals, making program recommendations, and being able to provide that kind of consistent approach then in our office. It's not to say some things don't happen later where it comes up that we discover somebody might have a problem, but as best we can, again, early on, we're trying to funnel those cases, make sure she has a chance to review them, and work with the rest of us in the district attorney's office related to any behavioral health needs. So Intercept 2 is that initial detention. Again, this is early on in that process. Usually if something's emerging, it's emerging as close to arrest, close to this booking process. So we do want to make sure that we're doing the assessments. And all of those things were implemented as part of the Stepping Up initiative. This sort of just lays out again early on what we do to try to make sense of and understand better what folks need early on in this process of being justice involved. We also have the bail review team. Now, Dr. Yinger had mentioned Team MISA as well, that looks at specifically those subcases, the severe mental health, drugs and alcohol needs. But the bail review team is for kind of everybody else. Meaning, we don't want folks maybe sitting in jail on like a low cash bail kind of thing. Maybe the only reason they can't get out is because of a cash bail, and they just need to post that. So we try to run those lists and make recommendations weekly. There's a bail review team where folks could potentially have that revisited, try to see if there's anybody that we could connect to treatment. Maybe they were missed somehow, came in a different way than central booking to the jail, and we want to be able to see and connect them to services. So the bail review team can be a good mechanism for that. Team MISA, we already discussed. In terms of the jails and the courts, we have the DUI repeat offender program, and that one is really for folks who have 2 or more DUIs. DUIs present a specific public safety risk. We know lots of folks, especially with 2 or more DUIs, most often have a substance use disorder and a co-occurring disorder of some kind. Repeat DUI offenders typically have that profile. But for purposes of drop court, it's early identification of somebody with that charge profile, and then placement into this court, getting them monitored, drug tested, alcohol tested, and making sure that if they are appropriate, say for a treatment court, or if they, you know, are appropriate for some other intervention, that they're getting that quite early. We're trying to, it's usually within a month maximum, that somebody is screened, placed, or otherwise assessed into that program. And it's more just of a diversion and connection program. It doesn't have the same structure as like a problem-solving court would, with, you know, weekly reporting dates or, you know, additional kind of supervision. But pretrial, there's a pretrial officer. They do have court every 2 or 3 weeks. And it's really an opportunity just to get the first person tested, connected, and expedite their case through if there's another program that they could get through. So it's not really fully a problem-solving court. We also have some interventions at the jail, intensive outpatient kind of programs that, again, COVID kind of derailed a lot of those efforts. And I think it would be beneficial maybe later as a follow-up to just even do a deep dive into the jail. But that's something we can certainly discuss later if folks have more questions about jail-specific services. We started in April of 2021 the Recovery Connections Court, which again is an opportunity based on those assessments and screenings that are being done in booking to divert folks, connect and divert folks who need treatment into those services and provide court structure. So it is modeled after the treatment courts. We do have court every single day. Many of the referrals we have had thus far are folks that probably will track into drug court when possible. So it's really speeding up that identification process, giving them an opportunity to get into treatment even earlier, kind of that acute stabilization type phase, report to a judge, build that rapport, and then go from there in terms of other maybe longer term criminal justice programming or appropriate treatment programming. And Ashley did discuss that the mental health court planning process again is underway as well. And I made an assumption here, which is always a bad thing to do, that folks know what a drug court or a veterans court or treatment courts are. But basically they're models within the court system where we bring together folks from human services, public defender, district attorney, probation officers, folks in all those various roles, the judge, of course, the judge is a key component. And we find folks that have usually longer histories, unfortunately, in our system, and have substance use disorder, mental health needs, but primarily the drugs and alcohol needs, and place them into these court programs where they can receive the intensive supervision, they can receive the drug testing. We give them benefits, cost breaks on any fines or fees. We pay for things. If they need to have drug tests, we cover those. We'll pay for treatment. We're able to do quite a bit in terms of trying to take the cost burden off these folks, but what we ask for in return in these programs is their time. And it's quite a time commitment to be able to do these things. So we try to juggle all the needs of life with, you know, work and other expectations of just being able to survive, provide as much support as we can as a justice system through grants, through departmental cooperation, different agreements there, to fund what we can, give folks those breaks so that if they are putting in that hard work, they have an opportunity possibly to kind of earn off maybe a charge reduction, or maybe not go to jail, and even though their charge and sentence would call for that, but give them the opportunity to kind of keep structured, keep at the treatment, you know, we're here, and enough time for those changes to kind of sink in and start to occur. Kristen mentioned earlier in her presentation, the certified recovery specialists, they have been, for drug court in particular, they've been a huge asset building in that support. We first started that program with the RACE project back in, I think, 2014 or 15. We tried to bring in more recovery supports for our individuals while they're in the court programs. And it's been extremely beneficial to have those supports. In veterans courts, we have mentors, not quite the same things. They're also, those folks are veterans who have served, and the person may have a recovery support specialist, or they might have a sponsor depending on their needs. But the idea is, again, to tie folks to the community, provide additional support, make sure that somebody can enter society again and stay there. We want folks to recover. We want them to get better. And these programs are a part of kind of that overall package approach that we're taking to try to make that happen. Oh, uh-oh. See, there I go. I clicked on a link. I figured if we had time, we could watch some videos, but we want to make sure we have time for questions. So I clicked on the wrong part of my slide. Last but certainly not least, there are the Intercept 4 reentry and Intercept 5 community corrections. We are working quite diligently right now with our reentry collaborative to kind of better build a working relationship, I guess say enhance that with our community service providers that serve a lot of our folks in the criminal justice system. We've had those relationships in the past, gotten feedback it's not enough how that works. So we're currently building out and restructuring this coalition to get a sense of how we can do better. Work release, that department it's kind of like they're sort of between the community full transition and the jail. They're kind of like right in the middle there. Gives folks a structured semi-correctional environment to kind of go as like a pre-launch into the community. They're instrumental in kind of helping continue that sort of stabilization process for some people. It usually depends. Maybe somebody doesn't have a place to go when they first get out of jail, or the home environment they might not go back to is maybe not the best, or they just simply, their sentence requires some time there. But this gives them the opportunity, if they're work release, to work or to go to school or whatever. So work release is a really important kind of intermediate sort of structure there to reentry. And probation services, once somebody fully reenters, we want to make sure that they are receiving proper supervision, that our probation officers are using tools to help them in assessment of how they should case plan for folks to help their clients achieve success in the community. And Ashley also talked about the mental health cases reentry coordinator position from the jail. So for those individuals who have those co-occurring needs, we do have someone who can help with reentry planning as well. And then in the community corrections, there are the specialized caseloads, probation services, or for like the drug court and vet court programs, or possibly mental health intensive officers. Those officers have caseloads. And then the utilization of ORAS. ORAS stands for Ohio Risk Assessment System. It's a fourth generation, I think, risk assessment tool. And it focuses in on all of these things that can help or hinder someone with success. They'll look at things like attitudes, antisocial attitudes, values, beliefs, kind of get a measure and understanding of kind of where the person falls on that realm, because those are linked to coming back to the justice system. And then these other kind of areas we can be responsive to: education, home environment, working history, drug and alcohol needs. That's predictive, whereas interestingly, mental health is not, but it is a responsivity factor. And so we use that tool to help the probation officer's case plan upon reentry. And this is a very high level view of what goes on at that point in the system. So from here, I know we gave a lot of information today, focused drugs and alcohol forensic, focused on stepping up initiative, which is kind of that mental health piece forensic. I'm gonna put up this lovely slide here quick. We will turn it over for questions, but I'm just gonna throw my contact information up really quickly and then stop sharing my screen. These are some upcoming dates for the Criminal Justice Connect. But here's my contact information, and Dr. Yinger and Kristen also put up their information. So please contact any one or all of us with additional questions. And I'm going to stop sharing my screen all right. And from here, it's about 1:15, so we have at least 15 minutes left for questions. If you can't access the chat, say you're on the phone and you want to ask one by phone, just let me know. Just unmute yourself. I'll try to see here if I can unmute you and manage that. So just to kick it off, it looks like there's one from Sarah Winch. Are there barriers to treatment for mental health because of limited inpatient beds? I know, Ashley, if you want to take that question.
We have definitely seen with COVID that waiting for inpatient beds can be a barrier. But what I have found, at least in the cases that I'm involved in, it kind of actually goes back to what Kristen mentioned earlier, that barriers to treatment. We can see that very same thing occur from the mental health side. And again, I can't speak for all general mental health until we have like a further discussion with the mental health administrator, as she would know more everyday stuff. But the cases that I get involved in from a criminal justice standpoint, I can tell you a couple weeks ago, I got a call of an individual at Dauphin County Prison, and really needed to go inpatient, very low charges. And so our office supported amending bail to unsecured to get the person inpatient. So I worked with a realm of people and we got that all set. Worked with the warden and were able to get the individual transported down to the Harrisburg hospital. That person stayed in the hospital for 2 days before transferring to PPI. And it really was a combination of things. The beds were full. This individual did not have insurance. When we find that people don't have insurance, it actually is a lot harder to get them inpatient. And the person, that was just that person. So, you know, we were able to make it work and we did get the individual to PPI. The barrier for that person literally was insurance and beds being full that were close proximity. So we were really waiting for beds to be released. Some other barriers, and again, these are all almost very identical to what Kristen mentioned. If someone has like a medical issue on top of that, some facilities may not feel equipped to take that individual. If the individual has a lot of drug and alcohol, so trying to find a facility that's dual, that they will serve drug and alcohol, mental health. And I know from the drug and alcohol side, I don't want to speak for Kristen, but I know she would mention the same thing, that if they're looking for a drug and alcohol patient bed, but the person has significant serious mental illness, that can be a barrier for them. We see it on the mental health side, that if the person has significant drug and alcohol and mental health, so it's really trying to find that right facility. And if that facility is full at that moment, we may have to wait. We've seen an increase in youth for sure. So taking out criminal justice, but in speaking to the mental health administrator, I feel relatively confident of saying this, that we've seen an increase in youth going inpatient, and a lot of increase with youth stuff going on right now. I do believe is associated with the pandemic. Youth have been hit with a lot of things this past year, and so rightfully so, we've seen an impact with their mental health and trying to get beds for them. So there definitely are barriers to getting someone into mental health treatment right now, just because we've had some limited inpatient beds. I hope that we work through this pandemic and we see some decreases with that, with the needs, and that we can get someone into outpatient. It is a lot easier to get someone into outpatient therapy as opposed to outpatient psychiatry. Again, insurance can be a barrier to that. A limited psychiatrist. It is hard getting a psychiatrist. We could never run out of psychiatrists. There's always a need for that, but not everyone wants to be a psychiatrist. But that's why oftentimes we find getting someone into psychiatry that there may be limited. There's definitely a several week wait. Last I checked, I know it was like a 4 to 6 week wait to even just get into having the intake appointment. But if someone just needs therapy, we can relatively do that within a week or two. But there's a lot of reasons for barriers, and unfortunately, because of those barriers, it definitely does not help someone with also battling maybe some charges in the criminal justice system. You know, waiting list for residential services. We haven't seen such a huge wait for that. So if someone does meet the criteria for residential, CMU has been able to get someone in, especially knowing that we have that new forensic CRR. That's not filled up yet. It's getting filled, but it's not filled there. So we've been able to get someone into residential. We've had to wait sometimes. I want to say in the beginning of COVID, we had more of a wait to getting someone into residential services because the beds were full, because they didn't want to discharge anyone or let alone bring someone in because of the COVID restrictions. So we definitely saw more of a wait period like no other at the beginning of the pandemic than what we're seeing now. I think some of the wait now is now that we're getting back to what I would like to hope normalcy. Now they're still filling all that backlog that they had from the pandemic. And we're seeing that even outside the mental health. You know, I was talking to doctors about a medical problem of getting surgery completely outside of mental health related, and had to wait several weeks because doctors were in the backlog of the pandemic. So it's definitely, unfortunately, impacting, you know, mental health and non-mental health. but we were absolutely seeing barriers, and hopefully, we can work through those. Our county mental health is fully aware of them. They are looking, how can they work with providers to get people in that do have some of those higher needs, especially related to criminal justice. Can we look at providers that strictly want to serve kind of that forensic population, and that ideally that they would always keep openings available for individuals that are, coming out into the community, so that way we're not having that be a barrier. So the county health administrator is looking into that. I know I've spoken to her, especially when we get into mental health court, as I know that's going to be a need. So looking at those providers, Commissioner Hartwick is a strong advocate of also looking at those providers, working with a few select providers that we know that will help serve that population. So definitely on our radar, but yes, we definitely do see a limited capacity right now, and I'm trying to work through that the best that we can.
Okay, yeah, and I see a response. She said, thank you, that's useful information. And grateful to see the end of the pandemic, and I agree. The sooner we can kind of turn back to normalcy, the better, because it certainly has had an impact on folks' needs. Any other questions to ask our presenters? We still have about 7 minutes. If anyone would like to ask anything else, either type it, or if you do want to unmute yourself, I can certainly, you can do that, and we can just go through that way. Any other questions? I know some of the people on this call, you're usually not shy. Okay. All right. Well, thank you, everybody. If there aren't any more questions, thank you, everybody, for joining us today. What will happen next is we're going to take this, have this rendered. We'll get a YouTube channel link so folks could view it later if they would like to. Like I said, it's a kind of a private YouTube channel. Our next in this series is going to be on September 16th, and it's on cognitive behavioral interventions. So when these topics were selected, the community asked to hear more about them. So we're coming up now on the last 2 in that original series of requests for presentations from your local government justice folks. So probably in the next month to 2 months, you'll see another kind of survey go out to find out what are some other topics folks want to hear about. And we'll be continuing these into 2022. Probably even have some in the evening related to other topics. I know Reentry has a education outreach committee. There'll probably be more requests for topics compiled through that group as well. And I see somebody else just popped in the chat here. Yeah, I will copy your email address down and then reach out to you then, because of however you'd like to be involved. We'd be certainly glad to have you. So I really appreciate everybody's time today. I'd like to thank our presenters, Kristen and Ashley, and have a wonderful day, everybody. Thank you for coming.
Thanks, everyone.